So, good afternoon, everybody. For today's discussion, we'll be discussing HIV prevention of mother-to-child transmission in the context of South Africa. So just a brief introduction. As we all know, HIV can be transmitted from an HIV-positive woman to her child during pregnancy, childbirth, and breastfeeding. Mother-to-child transmission, which is also known as vertical transmission, accounts for the vast majority of infections in children of the age of 0 to 14 years old. In addition to this, infections during pregnancy are a major contributing factor to perinatal morbidity and mortality. Without treatment, if a pregnant woman is living with HIV, the likelihood of the virus passing from mother to child is 15% to 45%. However, if ARV treatment and other interventions can reduce this risk to below 5%. The WHO has defined elimination of mother-to-child transmission of HIV and syphilis, which is EMTCT, as a reduction in the number of new HIV and syphilis amongst infants to a level at which they are no longer a public health problem. Excuse me. So the WHO defines these levels as the impact criteria for country validation of EMTCT for the two infections. Prevention of mother-to-child transmission of HIV includes preventing primary HIV infection in women and girls of childbearing age, identifying HIV infection as early as possible before or during pregnancy and postpartum, as well as providing the pregnant and postpartum women and their families living with HIV ARV therapy immediately on diagnosis and continuing this therapy through the pregnancy and breastfeeding periods. Women are then encouraged to continue ARV therapy for life. With regards to syphilis, the PMTCT of syphilis includes early detection of maternal syphilis and immediate treatment with a minimum of 1 injection of 2.4 million units of benzathine penicillin G intramuscularly at least 4 weeks before delivery. So while the WHO calls for the dual elimination of HIV and syphilis, South Africa aspires to eliminate all infections that are transmittable from mother to child by promoting the prevention of such infections. So these and this is so that early diagnosis and proper management to reduce maternal, neonatal, and child morbidity and mortality. So these infections include HIV, hepatitis, listeriosis, malaria, syphilis, TB, as well as Zika virus and others. So with regards to the challenges we face in South Africa, so just some background, in 2015, option B+, which is lifelong ART, irrespective of CD4 count or WHO staging, and birth PCR testing were implemented. So the birth PCR test provides an opportunity for early identification of babies who acquired HIV in utero and linking them to HIV care and treatment as early as possible. Monitoring of the infant PCR test positive around 10 weeks indicated a reduction in the mother-to-child transmission rate from 1.3% in the financial year 2016-17 to 0.9% in the financial year 2017-18. It's also of note that the Director General stated in the latest PMTCT South African guidelines that the challenge that PMTCT is currently facing is an increasing number of babies who acquire HIV infection during the postnatal period. Furthermore, there's been an increase in other transmittable diseases such as TB, hepatitis, and syphilis. So we can actually see the stats on the slide there that just show that it is on the rise, the other transmittable infections. So with regards to tackling the problem in South Africa, so to address this challenge, the guidelines were revised in 2019 and they provide guidance on the following. Firstly, with regards to ANC, it's strengthening of antenatal and postnatal care for both HIV negative and positive mothers, the introduction of a dolutegravir-based ART regimen, which is more effective in reducing the risks of transmission of HIV, and lastly, promoting integrated management of mother-baby pair by aligning PMTCT interventions with ANC visits during the antenatal period and EPI visits during the postnatal period. For those who don't know, ANC is the basic antenatal care approach, which South Africa has adopted. So I'm sure if you've all seen the obstetrics handbook and how it dictates when you need to bring the mothers back at a certain amount of weeks, those guidelines were actually drawn up as part of the ANC, and it just stipulates the basic things we need to check on mothers and what needs to be done at each follow-up ANC visit, and at certain weeks what needs to be done. So moving on, So, South Africa has dictated that the minimum standards of routine care for women of childbearing age and their families are best explained by the four pillars stated below. So, firstly, primary prevention of transmittable diseases, especially among women of childbearing age, preventing unintended pregnancies among women diagnosed with transmittable infections, preventing disease transmission from a woman living with a transmittable disease to her infant, providing appropriate treatment, care, and support to women, their children, partners, and families. So each of these pillars apply for TB, syphilis, malaria, hepatitis, listeriosis, Zika, and other infections. However, for time purposes, we'll only be focusing on the specifics of HIV PMTCT today. So I just, because the difference in guidelines are so significant, I've just decided to outline a brief overview of the changes from the 2015 guidelines to the 2019 November guidelines. Of note, the general approach is now more structured, and there's now an inclusion of preventing unplanned pregnancies and promoting safe contraception. And these are two significant deviations from the 2015 guidelines. We also now perform a viral load on the mother at delivery and 6 months postpartum for all women on ART, as well as 6 monthly during breastfeeding. Um, so now that dolutegravir has been added to our arsenal of ARVs, we've now replaced the previous regimen with a stat dose of tenofovir, lamivudine, and dolutegravir in a FDC, and then a single stat dose of nevirapine. So this is for the ART for the mother who is presenting in labor. We then obviously start lifelong ART the following day after appropriate counseling to understand her fertility intentions and contraceptive needs. Also of note now, we no longer do an 18-week PCR for high-risk infants, but we do a 6-month HIV PCR for all HIV-exposed infants. We also do universal testing now for at 18 months. So that's a rapid test for all infants, regardless of whether they were exposed or not to HIV. Obviously, we're not going to test the ones who are already confirmed HIV positive. And then lastly, the change is now that HIV PCR should be used as a confirmatory test for any HIV positive test result up to 2 years of age. We also, with regards to the definition of a high risk infant at birth, it's now considered to be a mother with no viral load in the last 12 weeks of ANC, or a mother with a viral load of 1,000 or more at delivery. With regards to the infant post-exposure prophylaxis, of note, we now stop nevirapine at 12 weeks only if the mother's viral load is less than 1,000 copies per mole. Otherwise, we continue until the nevirapine until the mother's viral load is less than 1,000 copies per mole, or until 4 weeks until until after 4 weeks after she's no longer breastfeeding. They also have significant more changes with regards to breastfeeding. Previously, it was only recommended for 12 months. However, now in the context of ART, they recommend 24 months or longer, which is in line with the recommendations for the general population. So just with regards to TB screening and the tuberculin skin test. So we now do a TB gene expert for all newly diagnosed women living with HIV or known positive women with a new pregnancy diagnosis. No TST is actually required. If CD4 is more than 350, we defer the TPT for pregnant women until 6 weeks postpartum. And if it's less than or equal to 350 during pregnancy, we initiate TPT for 12 months. Previously, also syphilis, hepatitis B, and malaria were not mentioned in the guidelines. However, there are significant protocols and guidelines in the 2019 version, but obviously for time purposes, we're not going to go through each of those. So moving on to the ANC visits. The way it's of note here, there's this concept of provider-initiated counseling and testing. So this is where women are not going to come and ask, or may not come and ask rather, for HIV tests. And it's actually our job as the doctors or healthcare workers seeing them at clinics that we should be offering them a test at their first ANC booking and visit. And if the mother is negative, we are supposed to be offering them a retest at every routine visit after that. We offer couple and partner testing to promote prevention, access to HIV care and treatment, and or manage discordant results, which is when one partner is HIV positive and the other partner is negative. If the woman and or her partner test negative, it's important to provide them with HIV prevention information such as condoms and other form of other forms of STI prevention, such as pre-exposure prophylaxis and so forth. Women who choose to not be tested should be offered post-refusal counseling, and they should be offered a retest at every subsequent visit. And obviously, if a woman tests HIV positive at any stage, we should be encouraging her to come and bring the children for testing, and obviously link them to an HIV care center where they can receive their treatment. So with regards to HIV, the treatment of HIV during ANC, of note, so for the sake of time purposes, I've simplified the ARV management algorithm on this slide. So pregnant women already on ART should continue their current ART regimen pending their first viral load results. Only if the viral load is less than 50 copies per ml and she's no longer in the first 6 weeks, offer her the option of switching to DTG. If a viral load is more than 50 copies per mol, manage her as per the viral load non-suppression algorithm. This will be shown a bit later in the presentation. All newly diagnosed HIV positive pregnant women are eligible for lifelong ART regardless of gestation, CD4 count, or clinical stage, and this was not the case in the 2015 guidelines. Of note, creatinine and CD4 count should still be done to determine the renal function and the need for prophylaxis for either TB, PCP, or cryptococcal meningitis. TDF3TC and DTG as a FTC is the preferred regimen for women who are newly initiating ART. And then known positive HIV women who are not currently on ARVs but are ART exposed, for example, they received previous prevention of mother-to-child transmission, should initiate a dolutegravir containing regimen. With regards to this ART exposed, they need to have either a documented viral load that was suppressed while she was previously on ART, then you would start the TLD. And if there's no viral load results available, or if hers was not suppressed, then you start AZT, 3TC, and dolutegravir. All women living with an HIV or living with HIV should be referred to a community healthcare worker to support adherence, breastfeeding, and retention in care pre and post delivery. So moving on. So with regards to the viral load monitoring and management slide, so I've just simplified the table on the left, sorry. So some key points from it are that newly diagnosed and initiated ART for the first time, you want to do their first viral load at 3 months on ARVs. And then if the viral load is less than 50, you repeat the viral load at delivery. For known HIV positive women who are already on ART, you want to do the viral load at the first booking in ANC. And if it's less than 50, you repeat it at delivery. And then for known HIV positive women who are not currently on ART but are exposed, for example, the previous PMTCT, as I mentioned earlier, and who are initiating a dolutegravir containing regimen, you must do the viral load at 3 months on ART, and then as the above two, you repeat it if it's less than 50 at delivery. If it's more than 50 in any of the above scenarios, you need to refer to the viral load non-suppression algorithm, which will now be discussed by Daniel.
Hello, doctor.
Hello, can you hear me?
Yeah, we cannot hear you now. Just did
Sorry,
you
I
stop
think I
your
was
presentation
muted.
or?
Hello, can you hear me now?
Yeah.
Hi, Dr. Pedkiva. Hi, everyone. Apologies, I had a few issues with my internet prior to this. So if you guys can't hear me at any stage, please do let me know. But thanks very much, Bhaveen, for that little introduction. I'm just going to go into a little bit more detail just in terms of the viral load non-suppression algorithm. I think really, it can be quite a complex process, but I think the take-home message at this point is just to remember a viral load more than 50 essentially in the antenatal period is something that is concerning. Bhaveen went through the various scenarios, and if we just have a basic look at the algorithm, we can see that viral loads between 50 and 1,000 are somewhat reason for concern, but are don't necessarily need to be acted on immediately. Whereas viral loads over 1,000, are a little bit more reason for concern. And just in terms of going into a little bit of background, I think the group from last week mentioned, the ABCDE approach, just in terms of coming to terms with why a patient may not be virally suppressed. Obviously, the whole process is multifactorial, and there's various social and psychological stresses that do play massive roles in mothers being adherent to their medication, or medication not being effective. So I'm not going to go into too much detail more than what's been said already. I think it's pretty self-explanatory in terms of that. Sorry, Bhavin and I are just presenting from separate locations, so I'll just say next when we go into the next slide. Next, Bhavin. So just in terms of the peripartum period, in terms of labor and delivery, as we've mentioned already, testing should be provided to all women in labor or presenting in the antenatal period. I think that's a self-explanatory and a given. I think it's important to highlight there that often cases of BBAs or born before arrivals, those mothers need to be treated in the same category. If their HIV status or viral load is not known at that stage, that obviously needs to be done, as it plays quite an important role in terms of the prophylaxis that the child will be receiving in the neonatal and infant periods. I think we often make the mistake of only looking at the patient as sort of the mother and the child. But our role as healthcare workers is also to acknowledge that the patient immediately in front of us is not the only person that is affected by the various diagnoses or treatments. So I think it's important to take the testing of partners and other children also into account when women have had a test or a positive result for the first time, particularly. I think that due to the nature of society, the stigma around HIV means that women often feel that they, shouldn't be making testing on their own. And I think it's important to bear in mind that women who refuse tests initially do need some counseling and may be amenable to tests later on. So we made a note of post-refusal counseling and how, retesting should be offered at every subsequent visit. It shouldn't be a case of mothers presenting, refusing testing, and then, kind of writing them off in terms of the rest of the antenatal period. Just in terms of the ARVs, Bhavin also mentioned most of what I'm going to go through now. Women that have a positive result and have already been initiated on an antiviral regimen should continue that regimen throughout the antenatal period, including labor. I think often, the labor ward can be quite a chaotic environment, and women tend to, slip through the cracks in terms of their medication. So I think in an ideal world, it's important to maintain that consistency, not only through the antenatal period, but also, during the labor period where things can get a little bit, more chaotic. Things become slightly more nuanced in moms who are newly diagnosed or who are positive that have not been initiated on ART. Particularly in the labor period, these women should receive a stat dose of FDC and either TLD or TEE. Obviously, appropriate counseling does need to take place, just in terms of the side effects or the potential side effects, particularly with regard to TLD, where there is a slightly increased risk of neural tube defects. So they get that stat dose of FDC as well as a dose of nevirapine. And then the workup for the initiation of ART should be done on that day of diagnosis, and then we can make appropriate lifelong ART decisions based on the various comorbidities or risk factors thereof. So as we've said, TLD is currently the preferred first-line regimen, despite the slightly increased risks of neural tube defects. The benefit of the dolutegravir based regimen does outweigh that risk. So the latest guidelines do recommend that TLD is the way to go in terms of that. So we've spoken about viral load monitoring in the antenatal period, where sort of the golden number, or the golden value, if I can say, has been a viral load of 50. When it comes to classifying infants in terms of their risk profile, that number changes to 1,000. So we'll go through that a little bit or in more detail in the following slides. But viral load essentially can be used as sort of a surrogate marker in terms of risk stratifying an infant in terms of their risk of contracting HIV via vertical transmission. So the most important viral load is the viral load at delivery. Obviously, we've mentioned already that it does need to be monitored throughout the antenatal period, but essentially the viral load at delivery will guide you as to whether an infant is a high or low risk. So any viral load at delivery below 1,000, you'll consider the child low risk, and then any viral load above 1,000, the child will be considered high risk. And we'll go into more detail in the coming slides. I think we've reiterated a number of times now, but counseling of the mother extensively and providing education and verbalizing challenges that she may face throughout the pregnancy, not just in antenatal or labor periods, but also in the postnatal periods, are steps that we can take as healthcare workers to empower the mother and improve insight. And I think that's ultimately the way that we are going to achieve our goal of elimination of mother-to-child transmission. Patients that have more insight, that are better educated, we know are more likely to be compliant and see the value in taking extra precautions in terms of their treatment. Next, Baween. So just in terms of care of the HIV exposed infant at delivery, there are a few basics, fundamentals that are kind of non-negotiable and don't change regardless of the situation. So any child exposed to HIV, i.e. a HIV positive mother, requires a birth PCR and a minimum of 6 weeks of nevirapine prophylaxis, which is obviously the dose is weight dependent there. But yeah, those are two sort of non-negotiables for any child born to an HIV positive mother. I think, in terms of providing quality care to these infants, the key here is just to identify whether the child is high or low risk. These algorithms are very simple to follow and, kind of provide answers for every kind of situation. But I think the key is just for us as healthcare workers to identify whether, this child is high or low risk. So as we said earlier, the delivery viral load is where everything or what we base our decision making on. So a viral load of 1,000 is the high risk, as we say, whereas under 1,000 is low risk. So excuse me. So as I was saying, that'll guide us in terms of treatment that we'll provide for the infant. So I mean, obviously, if the mother or the child is born before arrival, we need to pull viral loads as soon as we can, when the mother presents or whatever the case is, just so that we can make accurate decisions for the child. So as I was saying, every child that is born to an HIV positive mother is given nevirapine for the first 6 weeks. When it comes to high-risk infants, we continue that nevirapine for the first 12 weeks of life, at least. It becomes a little bit more confusing at this stage where, constant monitoring of the maternal viral load influences, the length of time that we use the nevirapine prophylaxis. The guidelines state that, we try and get the mother's viral load below 1,000 before we stop the nevirapine, or 4 weeks post cessation of breastfeeding. So the new guidelines have recommended exclusive breastfeeding for 6 months, up to 12 up to 24 months. So things become a little bit more complicated when it comes to working out exactly when we're going to stop the nevirapine. But we're going to go into breastfeeding again in a couple of slides. So on top of the nevirapine prophylaxis, high-risk children also need to be on zidovudine prophylaxis, which is a BD dose. So, you know, when it comes to managing these children, there are a few more, it does become a little bit more complicated, not only in terms of compliance, but in terms of the side effects of zidovudine, which are a little bit more significant than that of nevirapine. So, you know, I just want to reiterate and emphasize the importance of that delivery viral load. We really don't want to be subjecting these neonates to extended periods of zidovudine because we've had to treat an infant as high risk because we haven't had a maternal viral load at delivery. So I think it's just important to realize that there are quite significant consequences. It's not just a case of adding another drug to the regimen per se. Yeah, so we can just go on to the next slide there. So, you know, these next few slides, we'll just be dealing with the care of both the mother and the infant, probably be in a little bit more succinct way than I've managed to put it. But this is just in terms of postpartum care for both the mother. So this first slide now that we'll be dealing with is with regard to the mother. The next one will deal with the infant. So, you know, 6 days post delivery, we obviously don't need to be retesting HIV positive mothers at any stage. HIV negative mothers need to be retested now if they were not retested in labor. Just in terms of ARVs, obviously the mother is going to continue for life regardless of the period postpartum. As we're going to go into a little bit more detail with regard to breastfeeding, the breastfeeding period, we try and get the viral load below 1,000 there. So we're going to continue to initiate ART after the contraindications to any ART has been excluded. So, you know, we obviously we want to encourage the TLD or the dolutegravir regimen, but you know, there is room for efavirenz-based regimens should that need arise. So, just to highlight here, the postpartum period for a mother, not just the labor period, presents a little bit of a challenge when it comes to adherence. You know, now she's got another human being to take care of. Often there's a lot of, you know, I mean, it's even in simple things like often there may be family around and she may not have disclosed her status, and things like that all play a role just in terms of her adherence. So I think, as I was saying earlier, just to make sure that the mom is well, you know, informed, that she understands the reason why a viral load needs to be suppressed, all plays an important role in maintaining that suppression as much as possible. So just in terms of the viral load monitoring and management, throughout this time period, we're going to be checking on adherence. And Bhaveen did mention that, you know, community healthcare workers here can play quite an important role for mothers that aren't going to be following up at, you know, big tertiary centers. So those sort of platforms do provide support and encourage adherence, and kind of just that constant reminder that the goal is to be virally suppressed, you know, to reduce the chances of transmission to the infant. And then going forward, I mean, we've got 10 weeks, 6 months, and 18 months. You know, I think the most important milestone at this stage is the 10-week visit for the mum, where we want to repeat an HIV test for her there, just to make sure that, you know, there hasn't been a subsequent infection post-delivery or whatever the case is, because I think those kind of scenarios do happen every now and again and are quite unfortunate. You know, when the child is born has been born to an RVD negative mother, but has then been exposed, postpartum through breast milk, as the mom's now subsequently tested positive. All right, next term, therefore, Bhaveen. So this is just, care of the infant. I think this is where the EPI, plays an important role in just kind of maintaining and some sort of, I don't want to say surveillance, but helps to, keep things under control, if we can call it that. So as we said, there's a birth PCR which needs to be followed up post delivery and managed accordingly. So any HIV positive neonate then needs to be managed according to the guidelines that were set out by the team that presented last week. And then any HIV negative or PCR negative infant should continue on their prophylaxis based on their risk stratification of being high or low risk. So just to go into the testing, I think we did mention it a little bit briefly earlier that any child sort of under the age of 2 years with a positive HIV PCR or rapid test, because we do the rapid test sort of after 18 months, they should have their status confirmed with the PCR after that. So we do the PCR first line from birth to 18 months. With post 18 months, we do rapids, but that needs to be confirmed by a PCR after that. So that 18-month cutoff is important there. So as we say, just checking on the compliance of the mom or the caregiver at that stage is important. I think we've highlighted a number of times now that excuse me, that adherence is a challenge. So now when adherence is a challenge for an adult, it becomes even more of a challenge for a dependent, So I think this is where regular follow-ups or patients' regular exposure to the healthcare system is really important. Just, maintaining that understanding and just building on previous encounters is what's important throughout the infant's exposure or postpartum period. So we're going to repeat the PCR at 10 weeks just for all exposed infants who had birth PCRs that were negative. Obviously, birth PCR that were positive don't need to be repeated. Just to keep a tab on things and to make sure that the child has not seroconverted or whatever the case may be. So by the 10-week stage, we will have ceased the nevirapine prophylaxis for low-risk infants, but the high-risk infants would continue for at least another 2 weeks. As we said earlier, that 12 weeks of nevirapine prophylaxis is sort of non-negotiable in terms of high-risk infants. So we've stopped the nevirapine, the zidovudine prophylaxis at 6 weeks for the high-risk infant, and commenced the CPT, which is the cotrimazole prophylaxis therapy, just in terms of TCP infection. So that's all for all infants. All right. Then at the six month visit, we repeat the HIV PCR test for all exposed infants. So those will be on all the infants that have tested negative but have been exposed up until that point. When it comes to infants that have not been HIV exposed, that we do need to just monitor for signs of clinical infection, and repeat an offer to the caregiver with regard to an HIV test. If her test is still negative, then obviously the infant does not need to be tested. At the 18-month visit, we offer universal HIV testing. So that's when we switch over from the PCR to rapid tests. At that stage, if there's any positive tests, as I said earlier, we do need to confirm with the PCR. So that's just important to keep at the back of your mind. So just to reiterate this situation with nevirapine in high risk infants, we're going to continue for 12 weeks at a minimum. So the ideal scenario is to continue the nevirapine prophylaxis until the mother has a viral load below 1,000 or until 4 weeks post cessation of breastfeeding. So that's what's important there. When it comes to the CPT, we need to continue that prophylaxis until the infant is confirmed to be HIV negative 6 weeks post cessation of breastfeeding. So, you know, that becomes a little bit more complicated when you're doing 4 and 6 weeks based on PCR testing, but that is what the guidelines state. So just in the cases of where children test positive at any stage after the birth PCR, you immediately stop the nevirapine prophylaxis and initiate the antiretroviral therapy based on the guidelines, as we said. You do need to do a confirmatory PCR and then continue the cotrimazole prophylaxis as we said. Next one. So this is just a nicer way of, or a simplified version of what I've been saying. The nice thing about this is it gives the dosages with regard to the infants. I think I'd just like to point out again that zidovudine dose is a BD dose. And, you know, that is being given to high-risk infants, which kind of sort of implies that the mom is not virally suppressed, which brings into question of the question of adherence into the equation already. So if the mom is not virally suppressed and unlikely to be or less likely to be compliant, you know, a BD dosage of zidovudine for her infant is quite an ask. So I think, you know, that's where the antenatal period becomes really important, just to try and make sure that mom is aware that if she does not, if we aren't able to get on top of her viral load, it does have consequences on a superficial level. And then on top of that, the you know, the medical side effects when it comes to zidovudine, which include anemia and that type of thing, which is quite significant for, especially in the neonatal period. So yeah, that's just a little summary of what I've been saying so far. Next, Bhavin. So this is the question of breastfeeding is something, I mean, personally, that I haven't, you know, had a good understanding of prior to this, actually. So, you know, there's a lot of theories going around, and there's, I wouldn't say chopping and changing, but the guidelines have shifted somewhat. So basically, the important thing to remember here is that we should be treating HIV and HIV uninfected moms in a very similar manner. You know, that whether they're HIV positive or negative, the clear, well, the evidence suggests clearly that exclusive breastfeeding, it has massive benefits for infants, particularly in, you know, the South African context where formula becomes a massive expense. You know, when 30% of the population is unemployed or whatever the case is, you know, breastfeeding takes a massive load off the shoulders of caregivers, you know. So I think without doubt, we should all be advocating for exclusive breastfeeding of mothers, regardless of their HIV status or even their viral load. There is one exception to that, which I'll go through in a little bit, but I think, you know, counseling the moms and indicating, you know, that breastfeeding is safe is something that is really important. Just to start off, I think it's also important to counsel RVD negative mothers in this case regarding ongoing risk protection in terms of acquiring HIV postpartum. You know, a negative mother can still be infected during the breastfeeding period if precautions, you know, such as condom use or reducing the number of sexual partners is not taken into account. You know, so an HIV unexposed infant that then becomes positive in the postpartum period, you know, that does raise a lot of questions in terms of our ability as healthcare workers to accurately convey the spread of vertical transmission. So just because a mother is HIV negative at birth or when an infant is born doesn't mean that we need to, you know, just forget about her. I think it's important just to emphasize and reinforce those ideas in mothers that have tested HIV negative at birth. So as I say, all positive mothers should also be encouraged to exclusively breastfeed during the first 6 months. There is one exception to that, and that is mothers who are failing second or third line ART regimens. So that is mothers that are in second or third line regimens with viral loads over 1,000. So that would be the only exception to the breastfeeding rule, essentially. So all other mothers should be encouraged to breastfeed, with emphasis being placed on viral suppression to prevent mother-to-child transmission. So I think that becomes quite clear. So as we said earlier, the nevirapine will be continued for 4 weeks post cessation of breastfeeding in an ideal world. So that can be quite an extended period of time. You know, if the mother decides to continue intermittent breastfeeding up until 24 months, which is provided or advocated for by the WHO. I think in the South African setting that may pose a few challenges just in terms of the practicality of it. So my understanding was just to encourage that 6-month exclusive breastfeeding, and then, you know, we could take things, you know, on a case-by-case basis after that. Just a few practical points regarding the cessation of breastfeeding. So breastfeeding ideally should be gradually stopped over the period of a month. Studies have shown that, you know, an abrupt halt in breastfeeding can actually increase the viral load in the maternal breast milk. So should the infant, you know, there's a higher risk of transmission for the infant should subsequent intermittent breastfeeding start once, you know, the decision by the mother has been to stop. So a gradual progression, or not progression, a gradual stopping of breastfeeding is recommended with regard to that. And I think just to jump in there, I think, you know, we place a lot of emphasis on breastfeeding, but we also need to remember that moms do require counseling post breastfeeding, you know, so what the child diet should be like post breastfeeding. So just to emphasize that point as well to moms, to say, you know, yeah, you've managed to breastfeed for 6 months and that's been fantastic, but now, you know, there is a challenge just in terms of providing adequate nutrition for a child that is now stopped. So particularly in the South African setting where, as I was saying earlier, there are quite steep economic challenges being faced by huge numbers of our population. You know, practical means of counseling and information is important there. So, I mean, the WHO has made a number of statements with regard to breastfeeding, which, you know, do need to be interpreted in the South African setting or in the context of South Africa. So their statements with regard to breastfeeding were that any mother that is mixed feeding in the first 6 months should be encouraged to return to exclusive breastfeeding. However, mothers living with HIV and healthcare workers can be reassured that ART reduces the risk of postnatal HIV transmission in the context of mixed feeding. Although exclusive breastfeeding is recommended, practicing mixed feeding with formula milk is not a reason to stop breastfeeding in the presence of ARV drugs. So I think it's important to emphasize that first prize is exclusive breastfeeding with viral load or maternal viral load monitoring throughout that period, with the goal of being virally suppressed. If that's not achievable for various reasons, we should still encourage some breastfeeding as far as possible in terms of the mother with that ongoing antiretroviral therapy cover, as if I can say that. So, that the goal throughout the period is to be virally suppressed. Just because the mom isn't able to exclusively breastfeed doesn't mean that we should discourage mixed feeding at all. So then finally, their point was that mothers living with HIV and healthcare workers can be reassured that shorter durations of breastfeeding of less than 12 months are better than never initiating breastfeeding at all. So as I said, in the South African context, this extended period of breastfeeding does become a challenge for various reasons. So, advocating for at least 6 months is I think, adequate for a lot of or a large or our population. But if possible, that breastfeeding can continue up to the age of 24 months, as we've said already. All right, next one, Bhaveen. So just to wrap up, I think we do need to acknowledge, that there have been massive strides made in South Africa in terms of the prevention of mother-to-child transmission. And that has come over years and years of refining, the guidelines and changing, based on relevant and new research. So I think that's the first thing to acknowledge, that the fact that the majority of children in South Africa born to HIV positive mothers are being born as PCR negative is something that we should take a lot of heart from. But despite this, I think, the goal remains elimination. And we know that in the South African context, as Bhaveen mentioned right at the beginning, postnatal infection is currently the biggest challenge in terms of us as a healthcare system achieving elimination. So I think one thing that we need to kind of take advantage of as healthcare workers is to the antenatal period together with the labor period together with the postnatal period and the EPI provides a massive amount of time for us to interact with mothers and patients. And I think that's a unique advantage that we have in terms of ensuring elimination, that the number of encounters that we have as healthcare workers with mothers is second to none. I don't think there's any other situation where we have such frequent encounters with a mother or a patient. So, these frequent encounters should, in theory, provide us with greater room for counseling and education. We don't need to load mothers, with a load of information on their first visit. We can slowly build a very solid understanding of what HIV is, how to prevent its transmission, and how to achieve elimination, by building on a solid foundation of counseling and education of these mothers and caregivers. So I think we've illustrated that the path to elimination, almost squarely relies on the education and counseling of South African caregivers. I think we are simply facilitators in the process, just there to provide information and guidance, if I can say that, to these caregivers who ultimately, are the pillar of South Africa, and are the ones that are actually ultimately going to lead us to elimination. So yeah, thanks very much.
Thanks, doctors, for so comprehensive presentation. It's connected to our case presentation from today. And we need to remember the cornerstones of these guidelines and just to apply them when we've got such patients. Any comments or questions? Everybody keeps quiet. Okay. So I discussed with the other presenters about the presentation. It won't be enough time to present and to rush in the next 15 minutes, not even 15 minutes, it's 12 minutes to 4. And we won't be able to manage. So if you agree, we can do next week that presentation, which was due for today. And we can reduce a little bit the time for our case discussion, and we can give a chance to today's presenters to present the presentation next week. Are we agreed to do that?
Yes, we agree.
Yes, we agree. Thank you so much. So I want to make an announcement for tomorrow. We're going to have the CPD meetings. If you have a chance to attend from the clinic, you can do that. Otherwise, you're not obliged to be at the presentation, although it's an M&M presentation, and also our colleagues from your group is presenting. So see how you can arrange with the clinic the time that you have to leave. The presentation will be at 3 o'clock, but still you need to leave earlier to reach your homes. So see how you can arrange that and not to the clinics to suffer in that regard, that you've left the clinic earlier. The other thing is I wanted to mention to the group from Baragwanath is that 22nd is a public holiday. The group from Discoverers know about that. The roster has been corrected accordingly to that public holiday on the 22nd, which is a Monday. So the doctor who is responsible, your rep from the Bara group, is going to correct the roster and address that issue. So please don't try to be difficult with the doctor. So it's we also didn't know, our roster also needed to be changed for the medical officers, because we were not certain that that public holiday will be put on Monday. The public holiday is it's on Sunday, not on Monday, but it's been taken a decision to be celebrated on Monday. So don't obstruct the rep and bear with him. Are we having the agreement on that issue? I just want to hear from you guys. Can we just raise our hands if we agree not to obstruct the representative? Just raise your hand so I can see that you agree with what I'm saying. Yeah, Bonnie, Bavin, Kim, Daniel, Casmot, Sally, De Kock, Sanders, Nkelo. Okay. I haven't seen few hands yet. Yes. Jogi, Thomas, Ramjan. Are they from Discoverers, these people, maybe? Yeah. Okay, so let's try not to obstruct doctor, your representative, and the roster will be corrected accordingly. Okay, I wish you a good afternoon and good evening, and see you maybe tomorrow or next week. Okay.
Thanks, Maggie.
Thank you. Bye-bye, everyone. Bye.